Members, it's the appointed time and we have a quorum. I call to order the meeting of the panel on health services. Agenda item 1, information papers issued since the last meeting. Since the last meeting, the Secretariat did not issue any information paper. Agenda item 2, items for discussion at the next meeting. The next meeting will be held at 10:45 a.m. on the 11th of July. The administration suggests discussing the following 2 items. 1. Implementation of cancer screening programs and treatments and support for patients with cancers and rare diseases. 2. Progress update on enhancements of public healthcare services. Do members have any comments on these 2 items? If not, we're going to discuss the above 2 items in the next meeting. Agenda item 3, update on chronic disease co-care pilot scheme. I'm happy to see the government representatives here. Welcome Undersecretary for Health, Dr. Libby Lee, Deputy Secretary for Health, Mr. Eddie Lee, Commissioner for Primary Healthcare, Dr. Pang Fei Chow, Director of Strategic Purchasing Office, Dr. Chen Wai-lun, and Assistant Commissioner for Primary Healthcare, Dr. Tony Ha. I'll invite the administration to walk us through the paper first. Members who would like to speak, please press the request to speak button. Undersecretary, over to you. Thank you. I'm happy to be here today to brief members on the latest progress of the Chronic Disease Co-Care Pilot Scheme, or the CDCC Pilot Scheme. On the 13th of November 2023, we rolled out the 3-year-long CDCC Pilot Scheme. It provides subsidized diabetes and hypertension screening services to Hong Kong residents aged 45 or above with no known medical history of diabetes or hypertension. The scheme has been well received, as at the 31st of May this year, we've got about 130,000 participants. We believe that we'll be able to reach the target of having 200,000 participants early than expected. About 74,000 participants have completed the screening. About 40% of these participants, that is about 31,000 people, have prediabetes, hypertension, or hyperlipidemia. So it shows that the scheme is effective in helping people identify these symptoms and that it has achieved its target of early prevention, early identification, and early treatment. We have about 640 family doctors participating in the scheme, covering about 500 service points in Hong Kong. There is a bilateral referral mechanism under the scheme, and it helps identify people with symptoms. For example, one patient was diagnosed with severe narrowing of coronary stenosis, and some other participants had to receive follow-up treatment after the referral. This shows that the mechanism can refer complex cases to specialists for follow-up services. Under the scheme, we have rolled out 10 enhancement measures. 3 of them are important. For example, in early 2025, through strategic procurement, we have introduced allied health services. For example, we have optometrists, dietitians, as well as physiotherapists and podiatry services under the scheme. And this helps ensure we can provide services with better coherence. We are also providing screening and care services for the underprivileged. The first phase was launched in 7 GOPCs in March 2025. The government has plans to, by the end of this year, extend this scheme to all GOPCs in all 18 districts for the relevant services. The third enhancement measure was rolled out in March 2025. We are expanding the service coverage to include blood lipid screening so that we can achieve full coverage of the 3 highs under the scheme. Chronic illnesses. For that, we have a comprehensive platform. Through public-private partnership, we can, for those who have higher financial capability, provide comprehensive services. Through the primary healthcare network, we are ensuring that the underprivileged can get the same kind of service and support. Since the launch of the scheme, we have noticed that currently the participation rate of males is relatively low, only at 33%, especially those aged between 45 to 65. We will focus on promoting the scheme to those in specific industry. We will also roll out promotional activities on non-working days to raise men's health awareness and participation rate of the scheme. This weekend is the Father's Day. We'd like to appeal to all fathers to raise their health awareness. They should protect their health for their family. They should start from themselves by proactively participating in the scheme to receive preventive screening. For wives, please encourage your husbands, and for daughters, please encourage your fathers to take part in the scheme. I believe this is a very good Father's Day gift. The scheme has been very effective according to an interim report by a local university study team. According to cost-effectiveness data, as well as other information, this scheme has saved us about $2.7 billion in health expenditure. Through the cost-effectiveness data, we see that the scheme will enhance treatment outcomes as well as save health expenditure. It will improve people's overall health and bring about significant economic benefits. Moving forward, we have plans to expand the scheme so that more people can benefit from this scheme, which adopts an innovative approach. We have plans to expand the scheme into a CDCC platform. We will cover more chronic diseases under the scheme. For the first phase, we will have hepatitis B screening as pilot. We will also expand the drug list of the pilot scheme to cover those in the community drug formulary. I welcome any views from members. Thank you. Thank you, Undersecretary. We have 7 members, including myself, who have pressed the request to speak button. They are Mr. Chen Pui-Lun, Reverend Peter Kun, Dr. Tan Yue-heng, Ms. Rebecca Chen, Ms. Connie Lam, Mr. Kingsley Wong, and myself. 4 minutes for each member, including questions and answers. If you would like the administration more time to reply to your questions, please leave them time to do so. Mr. Chen Pui-Lun, please. Thank you, Chairman. According to the paper, we see that this chronic disease co-care pilot scheme has been effective. We have a target of having 200,000 participants, and by May, we have about 65% taking part in the scheme, so we have nearly reached the target. We see that under the scheme, about 40% of the participants are diagnosed with diabetes, hypertension, or hyperlipidemia. So I think this is very effective in helping people prevent chronic disease. I think what is more important is the participation of family doctors. I'm looking at the information here. Patients have to make a co-payment. Family doctors who take part in the CDCC scheme, 70% of the doctors participating in the scheme recommend the co-payment fee offered by the government. Family doctors can themselves adjust the co-payment fee every year. I'm worried that with a higher healthcare expenditure and with the adjustment of the fees of public healthcare services, will family doctors adjust the co-payment fee, which may in turn affect participants of the scheme? Are there any ways to encourage our family doctors not to adjust the co-payment fee within the 3-year period so that there will be more participants under the scheme and more people will benefit from the scheme? Second question. There was mentioned that there is a low participation rate among males. So what is the reason behind? Is it because men are in general busier, or is it because they cannot arrange time to receive the screening check? Or is it because they are scared of seeing the doctor? I think we need to do something to encourage men to take part in the pilot scheme. Undersecretary, I'll first address the question about the co-payment fee, and then I will see if my colleagues have anything to supplement for the other questions. On the point about co-payment fee, well, to be frank, even without this CDCC pilot scheme, any doctors may adjust their service charges or fees themselves. We allow family doctors to adjust the co-payment fee every year. However, they'll have to ensure transparency. That means if they change the co-payment fee, they will have to inform the Primary Healthcare Commission, and we will upload the information on our website. At the same time, participants have the right to switch to other family doctors. We hope that we can ensure price transparency so that participants can all go to the family doctors they want. As to whether we can mandate family doctors not to adjust the co-payment fee within the 3-year period, well, this is not one of the requirements under the scheme. So we will continue to allow family doctors to adjust the fee every year. However, they'll have to let us know about the increase. We will continue to monitor the situation. We see that 70% of the family doctors are charging patients the co-payment fee recommended by the government. We hope that the situation will continue. Now, turning to the participation rate of male. Why is there such a low participation rate among men? Well, normally, males wait for a long time until they see the doctor. They only see the doctor when they really feel unwell. It could be because of their personality. It could also be because of their work nature. So at the district health centers, we are imposing and opening hours that could provide convenience to men. Some of the more dangerous industries, for example, those working as drivers or in catering industries, they are considered as the high-risk groups. We'll see whether we can work with the relevant industries in the future so that we can offer certain benefits to employers if they allow their employees to receive the screening check under the scheme. Yes, Dr. Chung. When we designed the mechanism, we did not only look at the 3-year period. This is because we think that the scheme should be regulated in the future. For the first year, most family doctors keep the same fee level. A small number of family doctors increase the fee, and also there are a few family doctors that reduce the fee. We allow family doctors to adjust the co-payment fee every year. We will have more and more family doctors from the private sector joining this scheme. We will expand the scheme to cover more chronic diseases, for example, lipid blood testing as well as hepatitis B, and we will be able to take care of more patients under the scheme. That means there will be more family doctors as well.
Reverend Peter Kuhn, please. Thank you, Chairman. According to the paper, it is said that the number of family doctors and service points seem not to meet the demand in certain districts. Yunlong, Wantaisin, and Tuen Mun, where there is huge demand, there are only 40, 28, and 60 service points altogether. I think that people will be discouraged to use the service if they have to seek helps in another districts. So what measures does the administration have to encourage more doctors to participate in the plan so that we have more service points to make it more convenient for the people? Thank you, Undersecretary. Thank you, Chairman. I will ask Dr. Pan, Commissioner for Primary Healthcare, to take the question. Thank you. We have many family doctors across the territory in different districts. We're working on two different things. We know that people prefer to go to doctors near their workplace or residence. We've been talking to the people. Some of them actually opt to go to doctors in another district. We also, however, have the district health centers. For people participating in CDCC pilot scheme, we will issue a letter to the family doctor of the relevant patient to encourage them to join the scheme as well. Within 1 to 2 months, if the doctor does not reply to us, we will ask the patient to choose another doctor in the same district. Many doctors actually participated in the pilot scheme because of our invitation. Third, we want to make it easier for doctors to register for the scheme. That's why in the past 1 year, we have been inviting patients to choose the relevant family doctor when they go for consultation under the scheme. In 2026, in terms of supply of vaccination and with the implementation of the hepatitis B screening program, we will see how we can invite more doctors to participate. It's the most important to have patients be able to see the doctors that they most preferred. Reverend Peter Kun, any follow-up questions? Will the administration consider offering an incentive programs for doctors? For example, by giving recognition to family doctors who participate in the CDCC pilot scheme so that we have more choices for patients in districts with higher demand. Will the administration give, say, doctors participating in the scheme certificates showing their contribution and commitment to their community? Commissioner, please. Within this year, we awarded 25 family doctors with our exemplar certificates. Thank you. Dr. Zhang Yuhen. Thank you. I think that the CDCC pilot scheme is very effective in detecting hidden patients so that they can receive treatment as soon as possible. This is the goal of our policy. Now we have 200,000 participants in the scheme. Some 9,000 cardiovascular diseases was prevented, and that saved us $2.7 billion in terms of health expenditure. I fully support the pilot scheme. I have two questions. First, paragraphs 8 and 9 talk about the number of family doctors. Although there is an increase under the scheme, there are only 640 family doctors participating in the scheme that charge co-payment at a government-recommended co-payment fee level. but only 25 of them received recognition. I think that the participating doctors are faced with heavy workload. I hope that more doctors will participate in this scheme. So do we have enough doctors to meet the demand? Second, Annex 2, that's about the range of copayment level set by family doctors under the CDCC pilot scheme. For some family doctors, they charge as high as $800. That's far higher than the recommended level of $150 of copayment fee. How do we improve the situation? Because CDCC pilot scheme rely on government subsidy and procurement. How can we strike a balance between cost and effectiveness? Should we keep to the current co-payment level, or should there be any adjustment? I will ask Dr. Pan to talk about the point about family doctors. Thank you. At first, we had 300 family doctors. Now we have 600 odd family doctors participating in the scheme. We try to learn about why they joined it, and we also try to gauge feedback from the people. From that, we understand what concerns the doctors have. Some of them don't know how to operate the system because they have to enter the blood test level and screening outcome into the system. Currently, we encourage the doctors to participate in chronic illness treatment under the scheme. We believe that we do have enough doctors to meet the screening demand. We understand the concern. As mentioned by Dr. Chang, we are going to expand the scheme. We're going to offer subsidization for vaccination and hepatitis B screening. Hopefully, by this, we can attract more doctors to the scheme. Second, on the copayment fee level, we know that some doctors set the copayment fee as high as $800. The doctors have the right to make their own decision, but there were doctors who lowered their fees previously. The family doctors who charged $800 are very confident about themselves, but we try not to intervene too much because we want to know about the market situation better. So when we conduct a review, we will look into the reason why family doctors charge a certain copayment fee level. Thank you. Next, Ms. Chan Haiyan. Thank you. We all support the CDCC pilot scheme so that patients can receive treatment as soon as possible. You said that you have met targets early because there were already 130,000 individuals enrolling in the scheme, but only 75,000 people have completed the screenings. That's about 60%. Why is that? How long do the patients have to wait before they can complete the screenings? With 130,000 participants, only 74,000 people have completed the screening. Is it because we don't have enough doctors, because we have only 600 odd of them under the scheme? That's why the waiting time is longer. As you are introducing also hepatitis B screening, will the waiting time be even lengthened even further? How can you attract or encourage more doctors to participate in the scheme to shorten the waiting time for the screening? Second, according to the Department of Health statistics, there are about 5.6 percent of the population, that is around 410,000 people who are suffering from hepatitis B. So you may have to use ultrasound for screening. So what should the total cost be? The cost for hepatitis B screening could be different from screening blood pressure or diabetes. And what types of disease do you plan to cover in the future? Because now we cover hepatitis B, hyperlipidemia, so on and so forth. What will the ultimate cost be? Undersecretary, thank you. Let me take the first question regarding the waiting time for screening and the ultimate goal of the scheme. We thank Ms. Chan for the question. First, from participating in the scheme to the screening, it takes time. We don't aim at having all participants receive the screenings. The nurse will make assessment upon enrollment, and the individual will have to see the doctor, and the patient will then have to go through the blood test, and the doctor will then make a diagnosis to see if the patients have any disease. Usually within 1 to 2 weeks, the participants will have their screening completed. The longest time will be about 1 to 2 months. We think that the waiting time is satisfactory. As for our overall plan, now in terms of primary health care, we focus on whole person management. We don't want to focus on individual diseases or illness. We want each individual to have a family doctor so that they can receive treatment for their chronic illness at their family doctor clinic. For diabetes, hyperlipidemia, hepatitis B, these are our pilots. Our goal is to have each individual identify a family doctor, and if they need specialist care, the family doctor will refer them to the relevant department. That's the mechanism that we want to establish. As for our ultimate financial commitment, we want to achieve a better ratio. Currently is 2 to 8 or 3 to 7 between primary health care to hospital services. We want to focus more resources on primary health care ultimately. What about the second question on the cost of hepatitis B screening? How much are we going to spend on the hepatitis B screening? Dr. Pang, thank you. We act in accordance with WHO guidelines. There are some people who are at high risk. That's why they have to go through ultrasound. Some of them just have to go through or receive a blood test. That depends on the choice of the patient. We are going to roll out the pilot by the end of this year. We are making the preparatory work as of right now. That's why I won't be able to give you a concrete figure. We adopt a strategic procurement strategy to look into the supply and the price available in the market. Our principle today is a 50-50 in terms of our subsidy standard. Thank you. Ms. Lam So-wei. Thank you, Chairman. The government has been recently rolling out many public and private partnerships. CDCC pilot scheme is one of the examples. We see that is quite effective. But according to the administration's reply, we see that the number of family doctors and patients under the scheme is dropping. In 2023-24, we have 600 odd. 2024-25, 620. Number of patients went from 60,000 to 50,000. Is $150 of co-payment too low for some family doctors? It is said that most family doctors charge a co-payment fee at the government recommended level of $150. The administration said that some doctors charged $800 because they are very confident in themselves. Are they specialist doctors? Under the CDCC pilot scheme, many users are non-CSSA recipients. If there are more and more doctors who are going to charge $800,000, will that marginalize some of the patients? Thank you.
Undersecretary. Thank you. I think the scheme that Ms. Lam was talking about is the GOPC Public-Private Partnership Program. It's a different program. We have plans to integrate that program into the CDCC pilot scheme. For the public-private partnership program, as said, it will be included or incorporated into the CDCC pilot scheme, and with a gradual drop of participants of the public-private partnership scheme, it will not pose a significant impact. Now, on the point about the $800 of co-payment fee, families, doctors, regardless of where they operate their clinics, I believe they have their own thoughts about how much they should charge their patients. We have no plans to control the fee level imposed by family doctors as long as there is transparency. This is because patients have the choice themselves. Say we have some very expensive restaurants in Hong Kong, we cannot ask the restaurants to fix the prices of their dishes at a certain level. We have to allow the market to help regulate the fee level. If a patient cannot afford a certain family doctor, we would recommend the patient to opt for one who they find acceptable or affordable. Ms. Lam, do patients know that they are paying more if they are charged over $150? Yes, this is because when patients get to the district health centers, we will give them the information so they are aware of how much family doctors are supposed to charge. Mr. Kingsley Wong, I thank the administration for attaching importance to our men. This is because usually people emphasize more about Mother's Day than Father's Day. Men actually have been working very hard for their families. They are the breadwinners of family. There are many men in Hong Kong who work long hours. For security guards, they work over 10 hours per week or 10 hours per day. According to a survey, about 52% of security guards in Hong Kong suffer from obesity, and 81% of them suffer from high blood pressure. For drivers, it's not easy for them to go to toilets all the time, so they suffer from certain diseases as well. So, can you target certain trades and roll out screening checks for those in specific trades so that they can identify any potential symptoms or diseases early. Undersecretary, I thank Mr. Wong for the suggestions. They are some great ideas. We've been thinking of different ways to take care of our men. There have been measures to take care of our women. However, after the launch of the CDCC pilot scheme, we realized that men do not care so much about their health as compared to women. You mentioned whether we can target certain traits and roll out screening programs for them. We will look into this and see if we can incorporate them into our scheme. Thank you. Professor Chen Wing-Kwong, thank you. I have the following questions. First, during the 3-year period, we are targeting to attract 200,000 participants. We have about 130,000 participants now. It is expected that we will be able to achieve our goal earlier than expected. According to statistics, year 2024, people aged 45 or above account for over 50% of our total population, meaning that the participation rate of the scheme is rather low. Has the government set targets for the next phase of the scheme? If so, what is the next participation target? Currently, we have 3,000 family doctors, but only 650 of them take part in the scheme. That accounts for about 20% of all the family doctors we have. So my question is, are there reasons behind the low participation rate of family doctors? Are there measures in place to attract more family doctors to take part in the scheme? My third question concerns Chinese medicine practitioners. For diabetes, hyperlipidemia, there are ways from Chinese medicine practitioners to cure these illnesses, and there are enough clinical data to support this. However, there are currently no roles of the Chinese medicine practitioners in this scheme. Are there plans to include CM practitioners in the scheme so that they can play a greater role? For the first two questions, I'll invite Dr. Pang to reply. Thank you. When we set the preliminary participation target, we drew reference from different things, for example, the operation of district health centers, the family doctors we have, and also the lab testing services we can provide. We also have to look at how we can build our scheme. We have so many systems involved in the scheme, so we came up with the target of 200,000 participants for the first phase. Now for the underprivileged, the GOPCs will help provide screening services for them. On one hand, we want to take good care of the underprivileged, and on the other hand, we want to take into consideration people's affordability. Thirdly, we want to, through e-health, find out whether each citizen has their own family doctors. So there are different ways for us to explore how we can improve the scheme and increase the participation rate. Now, Family Doctor for All is a target for us. Over the years, there has been a lack of an effective mechanism to enable family doctors to take part in a pilot scheme like this. We have been collecting data from them. We have been getting their feedback on, for example, the subsidization model. We will analyze their feedback. Now, after participants pair with their family doctors, we also collect feedback from them, so we will continue to communicate with them. We hope that after we've launched the CDCC platform, there will be more participants. Thank you. Chairman, I'll talk about the Chinese Medicine Hospital. We've talked to Professor Chen about this before. The CM hospital will play an important role. We have the district health centers in all 18 districts. We also have elderly voucher scheme. We are currently drafting the CM development blueprint will definitely set out how we can enhance the role of CM in primary healthcare. We're talking to the relevant CM research and training center to see how we can make use of CM, for example, for pain as well as gynecology. Can we have the support from CM practitioners? We will cover this in the blueprint. Thank you. Mr. Tommy Chung. Of course, I support this pilot scheme. I'm just thinking about the following. Now, you're inviting people to take part in the screening checks. Take the collateral screening as an example. Say, if I'm found to have a few polyps, my insurers may tell me that this is not covered in the insurance plan if I am diagnosed with colorectal cancer. Say someone is diagnosed with 3 highs and he is told by the insurance company that any relevant chronic diseases will not be covered under the insurance plan. Well, I'm not sure how helpful this screening check is for those with or without insurance plan. I understand that you're encouraging the young generation to take out insurance early. Well, once they have done the screening checks, however, they may find out that a lot of items will not be covered under the insurance plan. Take intestinal cancer as an example. If I have completed the screening check and I am diagnosed with the cancer, then I may not be covered under the plan. Now I have another concern. Say I find out that I have 3 highs under the scheme. Of course, I'll have to take medicine. We've been talking about medication and drugs these days, and yesterday there was a motion debate about this as well. We realized that it's very expensive for private doctors to procure medicine. Say I am found to have hypertension or hyperlipidemia or high cholesterol under the scheme, then I'll have to take different types of medication. Well, you are adopting a public-private partnership model under the scheme, and you have family doctors from the private sector joining the scheme. Will patients under the scheme be able to purchase drugs under the community pharmacy program? It's way cheaper to get drugs from public hospitals. Well, are there ways to ensure that patients do not have to spend a lot of money to purchase drugs under the scheme? Well, family doctors are charging a lot because the cost for them is high, so they have to charge their patients the same level for the medication. Undersecretary, say I have completed a screening check and I'm found that I'm suffering from a certain disease, and the insurance company may increase the insurance premium. Well, not that they are increasing the premium. They may not cover that item under your plan. Well, we are looking at how we can increase price transparency in the private sector. People who receive screening checks, they have the awareness to protect their health, so the risks that they are subject to may be lower than those who do not care about their health at all. We'll talk to the insurance sector about this, however. Well, for those who receive screening checks, we believe that the chances of them suffering from chronic diseases is lower than those who do not take part in the scheme. And currently, medication is covered under the CDCC pilot scheme. Well, that means if they are found to have a certain disease, they won't have to pay for the medicine, right? At community pharmacies, we will roll out cheaper drugs. This is because we are adopting a joint procurement model with the hospital authority. Anyone who take part in the relevant programs, they can benefit from the cheaper drugs. Thank you.
首先啊，回
Mr. Chan Kim-por, thank you. I will address Mr. Tommy Chang's concern. I think that's reasonable. I think that the government has the responsibility to tell the patients that they have to inform the insurance company if they are diagnosed with 3 highs. Some people think that they don't have to declare their medical history if the illness was diagnosed some decades ago. I have received some complaints. I think that the administration should remind the people. Ms. Chen Hoi-yen said that we should encourage people to take out insurance as early as possible. I support that, but that's not my question. I think that the CDCC pilot scheme is very successful. Do you have a breakdown on the number of patients who have received screening? I think that 80 to 90% of the participants are diagnosed with 3 highs. I think that you have to focus on people aged over 50. For those that are most in need, don't actually go for screening. I hope that you will rectify people's mindset. Do you have any figures on the age groups of the participants? Undersecretary, thank you. We do support people taking out insurance very early when they're still healthy. I will ask Dr. Pan to supplement you with the figures. Is more likely for people to have 3 highs as they age, and if they already are diagnosed with 3 highs, they won't be able to participate in the CDCC pilot scheme. You see fewer people that are older under the scheme. That's because they probably were already diagnosed. Dr. Pan, we target people who have not been diagnosed with 3 highs. We believe that about 46% of the people aged over 65 are already diagnosed with diabetes and hypertension. We focus on people aged between 45 and 55. We want them to be able to be diagnosed as early as possible so that they can, say, exercise more, control their diet to manage their disease. The participants take 1.4 pills on average. That's far lower than HA patients. I think that your direction is right. I hope that we will increase the number of participants, because if people are diagnosed early, then they can control their health or manage their health better. Now it's my turn. On the point about insurance, some people are covered by their company. Will they be able to take out a personal insurance after they retire from work? Some people may not be able to take out insurance after they leave their company if they are diagnosed with 3 highs. As mentioned by Chan Kim-por, if people are able to manage their illnesses well, that's better for the insurance company. I think that the pilot scheme is great. We're going to have, say, breast cancer screening. We'll cover more diseases. Should we cover everyone in the territory? For people with means, perhaps we should lower our subsidization rate. Will we have a tiered mechanism? Thank you. We'll follow up on the issue regarding insurance on another occasion. We target underprivileged people with our public resources so that people will not fall into poverty because of medical fees. We will abide by the co-payment principle. We ask people to share part of the cost. If there is clinical evidence showing that the relevant screening is very effective, then the government will increase the subsidy level. Some screenings are perhaps nice to have only. The government will lower a subsidization level or even remove our subsidy. That's how we build our primary healthcare system. Ms. Judy Chan for the first round. Thank you. I don't have a question, but a suggestion. I think that this CDCC pilot scheme is great. Take myself as an example. I am 45 years old this year, so I am your target user or participant. My family members have diabetes. Last week, I received a call from the district health centers asking me to go for another checkup. I have not made an appointment yet. Regarding promotion and publicity, as the DHC was able to make a call to me, they should be aware of my medical history and my personal information. I think that the relevant DHC should inform me about also the CDCC pilot scheme. I think that the person making the call from the DHC should let me know more about the CDCC pilot scheme, as they were asking me to make an appointment for my checkup. Undersecretary. I think that when you visit the DHC, the relevant colleagues will tell you about the pilot scheme. Well, I think that before I go to the DHC, I should be made aware of the scheme over the phone. Thank you. Each person has their own reaction. Some people like to put down their phone when they receive such kind of a call. Ms. Chan Ha-yan, I have a suggestion. It is said that the proportion of male participants is rather low. I think that you should perhaps lengthen the operating hours of family doctor clinics, because many men only go for medical consultation during Sunday. Can we encourage family doctors to offer service between 8 p.m. and 10 p.m., or perhaps adjust the opening hours of their clinics so that we can accommodate to men working in shifts? Well, many clinics actually operate beyond 9 p.m. I think that they should have their clinics open on Sundays as well. Well, we have to look at a basket of factors. I believe that the men here would know why they are more reluctant to go to the doctor. We'll see how we can enhance the coverage. Mr. Chan Kim-por, thank you. I think that your suggestion was great. We do have grid insurance, and when the person is retired, they can shift to personal insurance. And we're not going to exclude the existing disease they have. So I think that the retirees should ask their insurers to see if they offer such a service. I think that concludes this item. Now we move on to the next one, development of community drug formulary and community pharmacy program. We have Dr. Libby Lee, Mr. Eddie Lee, Dr. Peng Fei Chao, Dr. Chen Wai Lun, Dr. Tong Ha King Heng, and Miss Annie Lee. Would the Undersecretary walk us through the paper? Member who'd like to put questions, please press the request to speak button. Thank you. Thank you, Chairman. I will brief members on the latest progress made by the HHB in developing a community drug formulary and launching a community pharmacy program. Let me point out the structural problems faced by public healthcare system. The price discrepancy between the public and private sector is 10 times. That's why people tend to rely on public healthcare systems for drug. This kind of imbalance pose further burden to the healthcare system and hamper a sustainable development. Currently, we have not made full use of the role of the community pharmacies. That's why in Q4 2025, the government formulated the community drug formulary, and we have also rolled out the community pharmacy program in phases starting from the fourth quarter of 2026. We want to enhance the drug supply and to alleviate the burden on the public healthcare system in order to enhance the safety and effectiveness of the drugs. There are two characteristics to the CDF. We're going to classify CDF into 3 levels. Level 1 will mainly comprise non-patented drugs. Level 2 will cover specified patented drugs and drug categories, and Level 3 is tentatively classified as a category for special drugs. The differences among the 3 levels in terms of drug inclusion, mechanism, scope, and application, as well as mode and subsidy and co-payment and details will be announced in due course. The tiered mechanism design takes into account factors such as market characteristics that will reduce drug wastage. We will adopt a joint procurement strategy among the community formulary in order to provide drug with reasonable price to lower people's financial burden. The drugs in the CDF will be selected from the HA drug formulary, and the HA will review the safety and coverage of the network to make sure that the drugs in the CDF and the HA is equally safe. The community pharmacy program will recognize the role of the pharmacies in the community. There are 2 modes under the CPP. We have CPP community that offers service to the regular members of the public. Second, we have this CPP RCH, which will provide patients living in RCH with services such as drug dispensing, reconciliation, packaging, and management, as well as drug dispensing systems and other relevant professional value-added pharmacy services. The government has established a working group on community pharmacy and an advisory group on community pharmacy to support the development of community pharmacies in Hong Kong. To offer support and advice on the development of community pharmacy services, we have also formulated a service standards and quality assurance system for community pharmacies. We also have the advisory group on community pharmacies, which is conducting study on the criteria and service models to be stipulated for community pharmacies providing government subsidized primary healthcare services. People are generally supportive of these working groups and advisory groups. The government, in enhancing the role of pharmacies, want to improve the allocation of healthcare resources to make sure that people can receive drug use guidance from pharmacies near their homes. I welcome members' questions on the CDF and the CPP. Thank you.
Let me read out the names of members who've asked to speak. They are Mr. Chen Puilen, Ms. Rebecca Chen, Dr. Tan Yueheng, Ms. Jovi Chen, Mr. Peter Xu, Mr. Chen Qingpo, and myself. 4 minutes for each member, questions and answers inclusive. Mr. Chen Puilen, please. Thank you. On the community pharmacy program, I have 2 questions. According to the paper, there are 600 registered community pharmacies with 700 to 800 registered pharmacists practicing in the community. It looks like there is enough supply. However, we have to enhance the professionalism of community pharmacists. Because they have to offer counseling as well as value-added services and so on. The existing practicing pharmacists, they mostly offer drug dispensing services. For those who will offer value-added services, will they have to enhance their competency and professionalism? If they are required to do so, will we have enough such pharmacists? Secondly, for the community pharmacy program, pharmacies that want to take part in the program, they'll have to meet certain requirements. For example, manpower requirements concerning information systems and so on, in order to meet the service standards. If they have to meet all these requirements, what kind of incentives will be provided to them to join the community pharmacy program? Lastly, under the existing elderly voucher scheme, those aged 65 or above, they can use vouchers to make the co-payment fees for example, consultation services as well as lab testing services. In future, will elderly participants under the scheme be able to use their elderly vouchers to buy drugs from the community pharmacies? Thank you. Undersecretary. On the question about pharmacists, I'll ask Dr. Pang to reply. I'll talk about the point about voucher scheme. Dr. Pang? We will issue guidelines for pharmacists, and there will be a set of guide for pharmacists in the future. We think that training is crucial. So over the past 2 years, we've been drafting the guidelines, and taking part in training courses is compulsory for pharmacists to take part in the program. We will progressively enhance the professionalism as well as the quality of service of the pharmacists taking part in the program. Moving forward, we will continue to talk to the trade to see how we can better draft or formulate the primary healthcare guidelines for community pharmacies. We ask subsidized pharmacists to receive certain training. Over 100 pharmacists have received the relevant training so far. We will continue to talk to the training organizations to see how we can do better. So we will work on training, the guidelines, as well as the reference framework for primary healthcare. Now, currently there are some 600 registered pharmacies in the community. We want to have 4 to 5 pharmacies taking part in the program in each district. If we launch the scheme fully, there should be 80 to 90 registered pharmacies under the program. As to whether we will expand this program further, we will look into this after we've rolled out the first phase. Now, the program is quite attractive for community pharmacies. Currently, very few community pharmacies offer professional services. They rarely offer dispensing services or consultation services. So once we've launched this program, we'll be able to see different types of professional services provided by community pharmacies. And this will help community pharmacies enhance their professionalism. The government is offering subsidy to participating pharmacies, so this is quite appealing to them. According to our consultation, community pharmacies are quite interested in making the relevant investments in order to participate in the program. Undersecretary, now on the point about the elderly healthcare voucher scheme, drugs offered by community pharmacies are relatively cheaper than those offered on the market. We want to encourage elderly participants under the voucher scheme to receive primary healthcare services instead of using the vouchers to purchase drugs or medical devices, but we will see whether there's room for us to expand the program in this regard. Thank you. Ms. Rebecca Chen, I support the community pharmacy program. Like the previous item we've just discussed, in relation to the way to take medication, well, I think it's better to have professional pharmacists to monitor our patients in taking drugs, and this can really help control their medical conditions. At the community level, I see that many people with low blood pressure, they take drugs themselves, and those suffering from diabetes, they also take a lot of drugs themselves. So I visited some large-scale community pharmacies launched by charitable organizations, and I think we should speed up the launch of the community pharmacy program. We have some 600 registered pharmacies already, and there are registered pharmacists working in these pharmacies. How can we speed up the implementation of the CPP? Well, the HA has been shortening the time for dispensing medication and drugs. We want to reduce the burden for public hospitals and divert patients to community pharmacies. Those who visit the community pharmacies, their medical conditions are rather stable. They don't necessarily have to go back to the public hospitals to get drugs and have to wait for a long time because of that. Why do you have to wait until next year to roll out the program? Can you not roll out the program with just 1 or 2 participating pharmacies first? Well, this is because the way of dispensing drugs by the HA has already changed. Secondly, in order for a registered pharmacy to be upgraded to a community pharmacy under the program, how can they meet the relevant requirements? Well, you said that community pharmacies are willing to join the program, so how can we boost their incentives? Also, you said that you will regulate the drugs offered by community pharmacies, and the drugs to be included will be selected from the HA drug formulary. Will that limit the types of drugs to be offered by community pharmacies under the program? Can drugs currently offered by commercial pharmacies be included in the program as well? Now, according to paragraph 4 of the paper, you want to offer cheap drugs under the program. If the drugs are not cheap, will people go back to the pharmacies of public hospitals again? Undersecretary, there was a question about whether we can expedite the launch of the program. I'll invite Dr. Chen to answer all these questions. As to whether the drugs to be offered will be sold at a different price compared to those at the HA, well, basically the prices should be the same. I'll ask Dr. Chen to supplement. Dr. Chen. This community pharmacy program to be rolled out is a breakthrough in Hong Kong. It is crucial for primary healthcare development, so we do want to implement the program as soon as possible. However, there are certain obstacles we have to overcome. First, on suppliers, we'll have to talk to the pharmaceutical companies. Currently, on the tendering documents from the HA, there's no mention that they'll have to work with us under the mechanism. We'll have 100 types of drugs and then on the list, and then the number will be expanded to 200. So we've been consulting the drug suppliers, but most of them support this program. Also, we need to have pharmacies. We have to make sure that pharmacies are competent to take up all kind of work. They'll have to meet the relevant requirements concerning manpower, information system, and so on. A lot of them aren't able to meet these requirements now. So, apart from conducting tendering exercise, we'll have to leave time at least 6 months for pharmacies to get prepared. So there are pragmatic or realistic reasons why we cannot roll out the program now. Also, we have different prescriptions from doctors every day, and we need a computer system to handle all the data. For the government to launch the program, we need a computer system that's compatible with that of the government from the pharmacy's side. So we believe that we will be able to roll out the program next year. Dr. Pang? Starting from last year, the Primary Healthcare Commission has been in talks with different organizations in setting the standards for pharmacies. Over the past 6 to 9 months, we have come up with the relevant requirements, and now we are at the consultation stage. We are collecting information from district pharmacies. We want their feedback because this is our first time setting the relevant standards for community pharmacies. We hope that we'll be able to widely apply these standards, and we hope that these standards can help improve the services provided by the pharmacy, including the quality of service offered by the pharmacists in the pharmacies. So we hope that we'll have the guidelines ready soon. Next, Dr. Tan Yueheng. Thank you. I completely support the community drug formulary as well as the community pharmacy program because they will benefit our people. For the same kind of drugs, the price can differ by tenfold between the private and public sector. And drugs offered by the public sector, they are as cheap as 1/10 of the price offered in the private market. So many people turn to the public sector for drugs. I hope that the formulary as well as the pharmacy program can reduce the burden of our public healthcare system and promote the development of primary healthcare. We want to speed up the implementation of the pharmacy program. Now I have the following questions. First, on the progress. The formulary as well as the pharmacy program, they are under one umbrella. You need drugs in order to build pharmacies. So the drug formulary is closely connected to the pharmacy program. How come you're working on the drug formulary first and then you are developing the community pharmacies? Would it be possible to work on both the drug formulary and the community pharmacy program at the same time? Can the two be launched at the same time? Just now I heard that there are some hurdles that the administration has to overcome. If we look at the drug formulary and the community pharmacy program as one project, perhaps that can speed up the progress of the administration. Just now you said that you will conduct tendering exercise. Well, drugs to be offered by community pharmacies as well as those offered by the public hospitals, they will be at a similar price. If that's the case, I think people will still go to the public hospitals for drugs. This is because they have high credibility. How can we ensure that drugs offered at the future community pharmacies will come from the same source as that of those drugs offered by public hospitals? We'll have to make sure that there will be vibrant businesses in the community pharmacies in order to boost people's confidence. How can you ensure that drugs offered by community pharmacies are as safe as those offered by public hospitals? You'll have to work on your publicity in order to do so.
Undersecretary, I will ask Dr. Chen to elaborate about the progress of the CDF and CPP and the difference between of the drugs between CDF and the HADF. Well, CDF and CPP complement each other, but they are not completely the same, because CDF supplies drug to private doctors participating in primary healthcare system for their patients. We're going to announce the mechanism by the end of this year, and we're going to work with pharmaceutical companies soon after that. And hopefully by the middle of the next year, we can launch it. For CPP, it will launch in phases starting from the end of next year. We think that the CDF and CPP complement each other, and we think that the current timetable allow us flexibility. Second, patients can either have their drugs prescribed at the family doctor's clinic or the HADF. If the price of the drug is similar between the public hospital and the private clinics, patients usually go for private clinics to collect their drugs, and clinics are able to offer more personalized service. That's why we encourage CDF to offer value-added service by, for example, formulating a plan for the patients. Thank you. Next, Ms. Jovi Chan. Thank you. I understand that CDF and CPP are crucial to the government reformation policy. First, how many drugs are we going to cover under the CDF? The government said that as of right now it's 200 to 400. However, it is said that we already have 1,500 in the HADF. So does that mean that people won't be able to purchase many drugs in the CDF? As we include more drugs in the CDF, do we have a timetable for that? Second, number of CDFs. The papers talk about the quality and the prices of the drugs. I think that we have to make the locations of the CDF more convenient. Will the government plan for the CDF in accordance with the population? For Kaiting, we have 500,000 people, however, with only 10 pharmacies. The FTU suggested the administration to work with the community organizations to expand the coverage of the community pharmacies. I will ask Dr. Chan to answer the question. Thank you. Regarding the CDF, it targets underprivileged people. We have many drugs under Tier 2 and Tier 3. There are special drugs to be prescribed only by specialist doctors. That will not appear under the CDF. So approximately, we're going to cover 200 to 400 drugs. under the CDF. I think that will meet the primary healthcare needs of the people. We think that the number is reasonable. We will take a progressive approach. First, we will establish a mechanism on drug inclusion. We adopt the same mechanism as used by the hospital authority, and it's very effective. We don't think that we have to create a new one. Every year, we're going to review the list of drugs to see if we have to add any. As we expand the CDCC pilot scheme and other primary healthcare programs, we're going to cover more types of illness, and we expect that we are going to make 1 to 2 adjustments every year to include more drugs to accommodate the more types of disease that we're going to cover in the future. There are about 600 registered pharmacies in operation. We don't think that many pharmacies will be able to join the CPP. We have 2 schemes. One is a CPP, and the second is the primary healthcare program. The pharmacies will have to adjust their resources to see how they can meet our requirements. Our target is to have 4 to 5 pharmacies in each district, but the more the better. We welcome more pharmacies in the same district, but we have to take it step by step. We'll start the program next year and to see what we should do after that. After Mr. Shiokawa has put his question, I will draw the line. If there are other members who would like to put questions, please press the button as soon as possible. Mr. Xu. Thank you. The administration is trying to make better use of the community pharmacies to lower the drug price. I support that. According to paragraph 20, the administration said that in the 4th quarter of 2024 and between May and July 2025, the government will consult different sectors. Are you going to consult the pharmacy associations? I will ask Dr. Chen to take the question. Thank you. We have 2 models under the CPP. We have the RCH version and the community version. We have already conducted 2 rounds of consultation. As for the pharmacy associations you mentioned, we have already talked to them. We are also going to consult the service suppliers of computer systems because they have to develop software to support the community pharmacy. So we have conducted a few rounds of consultation. The feedback was very positive. Pharmacies are already preparing for their participation in the scheme. Some companies or pharmacies may offer professional pharmaceutical services. They are looking into whether they should obtain a license. We have many residential care homes in Hong Kong. They are looking into, well, some of them are looking into whether they should also provide community pharmacy services. We're going to disclose more details as soon as possible so that interested parties can prepare for their participation as soon as possible. Mr. Xu. Thank you. The answer is very detailed. You said that you're going to procure drug in bulk. That's why the price procured by the administration is only 1/10 of that in the private market. You said that you want fewer people to have their drugs dispensed at the public hospitals. But as your drugs is priced at only 1/10 the level of the private market, will more people who usually go to the private clinics opt for the public hospitals instead because of the low price? Dr. Chen. The drugs under the CDF will be lower than those offered in the private market. Patented and non-patented drugs will differ very significantly in terms of their price. Our focus here is primary healthcare and the patients participating in the primary healthcare program. So not anyone can obtain drugs from the CDF or the HADF. Hospitals usually offer Tier 2 and Tier 3 service. Unless the GOPC has participated in the primary healthcare program, they won't be able to offer the drug at a price under the CDF. Dr. Sari Lee, thank you. I believe that people support the CDF and CPP. Because people will be able to obtain drugs at a lower price under the schemes. I'd like to know more about the actual operation of the formulary and the program. So the drugs under the CDF, do they have to be prescribed by the doctors? Say if a person feels DC, can they just purchase drug directly from the pharmacy? Do they have to obtain prescriptions from the doctor? Second, we debated yesterday on how we can strike a balance between public and private healthcare systems and how we can lower the demand for public hospitals. Are you trying to encourage more people to obtain drugs at community pharmacies instead of going to follow-up consultations at the public hospital? Third, the drug price of the public hospital is very low. However, that from the private hospital is very high. I think that the cost of seeking medical service mostly has to do with the drug price. So will the administration consider separating medical consultation from drugs dispensary? Undersecretary, all drugs under the CDF needs to be prescribed by the family doctors. For those that don't need prescriptions, people can just go to a regular pharmacy. People can purchase drug at cost from the pharmacies at the CDF. We only offer the drug at such a low price under the CDF for participants of primary healthcare program or participants of certain government schemes. We keep an open mind to any suggestions, but we will only review our mechanism after the two programs have been in place for some time. I think that we should be selling drugs under the CDF that don't need prescriptions from the doctors. I don't understand why you don't sell non-patented drugs under the CDF, because a Panadol is very expensive. Second, on the distribution of community pharmacies, Well, I hope that the Undersecretary will look into the percentage of senior citizens in a district when they plan for the number of community pharmacies to be located at a particular district. As we all know, there are many senior citizens in Wong Tai Sin. I hope that you will put in place more community pharmacies there. Will you consider it? Thank you. Undersecretary.
其他嘅服務咧，
Unlike other types of services, well, as long as the community pharmacies have the relevant resources and manpower, they will be allowed to take part in the program. We will not set a cap on the number of participating pharmacies as long as they meet the standards and requirements. Any follow-up or supplement? Yes, Dr. Chen. We want to adopt a whole person approach. That means doctors will prescribe medication for patients based on the patient's conditions. So patients who go to community pharmacies for drugs, they must have the doctor's prescription. Patients will be able to get all kinds of drugs covered in the doctor's prescription. Will you consider the first point that I suggested? For a lot of drugs that do not require doctor's prescriptions, will they be offered in community pharmacies? Say a person with osteoporosis and need to take calcium, he may be able to get calcium from the community pharmacies. Well, for drugs, you'll need a doctor's prescription. Well, I think community pharmacies has a role to play. Well, without collective procurement, it's quite expensive for community pharmacies to procure drugs these days. I think you have to think about this. For some simple symptoms, you can actually get simple drugs. That's what a lot of people do nowadays. Well, that's in relation to the value-added services. That is, they could consult pharmacists on what kind of drugs they should take. Well, community pharmacies in future will offer personalized services in this regard. I have something to add. I think we have to strike a balance here. We have to take into the interests of different parties. We may be able to provide convenience for patients through the program, but there could be divergent views from other parties. I think that even if community pharmacies sell those drugs that I mentioned, it wouldn't be a significant impact for them. Well, there is collective procurement model implemented on the mainland, so we can learn from their model. Well, some other members have requested to speak for a second round, but I already drew the line. Yes, Mr. Peter Xu. I just have one question, one quick point. According to Dr. Chen just now, the administration is currently consulting the trade. Well, have you consulted the Pharmacy Association of Hong Kong and Kowloon? They told me that they are covering some 400 community pharmacies, but they are not consulted. Yes, please be brief, administration. Well, we have representatives from that association in our consultation group, and on non-official or non-formal occasions, we've also talked to them. So you want a consultation session dedicated to that association, is that right? Well, they represent a few hundred pharmacies, so it's not enough for you to just talk to a few representatives. Please arrange a consultation session just for that association, please. Well, I have a question myself. Well, community pharmacies that are operated by NGOs, they get subsidies from the government, but those pharmacies offer help to those in need. They are not for everyone in Hong Kong. So this is a great first step. I think moving forward, for pharmacists who want to set up their own community pharmacies, you should encourage them to do so that you can leverage market forces fully to ensure competition. You may want to encourage existing pharmacies to transition themselves into a community pharmacy under the program. Well, there shouldn't be community pharmacies just run by NGOs. Well, NGOs, they get a lower rent and they don't have to take into consideration rental issues, and they get a lot of subsidies from the government to set up their own community pharmacies. Yes, we are aware of this, so under the program, we will encourage pharmacists to set up their own pharmacies, and we want more pharmacies in each district. Thank you. Now we come to agenda item 5, integration of women health services. We again, for this item, have Dr. Libby Lee, Undersecretary for Health, Mr. Eddie Lee, Deputy Secretary for Health, Dr. Pan Fei Chow, Commissioner for Primary Healthcare, and Dr. Christy Lam, Assistant Commissioner for Primary Healthcare. Let's invite Dr. Christy Lam to join us. And Undersecretary, please walk us through the paper. Members who would like to speak, please press the Request to Speak button. Thank you, Chairman. Now I will brief members on the integration plan for women health services and the implementation progress. The government attaches a lot of importance to women's health, and we strive to, for women of different ages, offer quality service as well as support. We have consolidated resources for the maternal and child health centers under the Department of Health into this service scheme. There will be women wellness satellites as well as district health centers and the GOPCs from the HA. And through these, we will offer support to women. We want to make sure good use of resources and efficiency. We will in phases set up 3 women wellness satellites in Hong Kong, Kowloon, and New Territories to replace women health centers. These women wellness satellites will offer services, personalized services for those aged 60 or above. The WWS in Taiwan commenced operation yesterday on the 12th of June, and the ones in Kowloon and the New Territories, they will commence operation in September this year. The Tonghua Group of hospitals have already set up transitional service points in North Point as well as in Yau Ma Tei. From January to the 1st of June this year, over 680 women have received initial assessments from the nurse clinics under our health centers, and some of them have been diverted to the women wellness satellites for services. So we have achieved results. In order to tie in with the services provided by women wellness satellites, we will step up education and promotion, and through diversified activities, we will enhance women's health awareness. The women's wellness satellites offer different types of services, including screening for breast and cervical cancer. There are also services to help women devise personalized preventive care. For those in need, we also offer them menopausal health counseling, breast health awareness, incontinence prevention education, and pelvic floor muscle training. It is expected that we'll be able to serve 30,000 women in need every year. WWS is looking into rolling out self-funded value-added services starting from the 3rd quarter this year, such as the provision of 3D breast ultrasound scanning services, vaccination services, HPV DNA testing, and so on. WWS services adopt a co-payment model like primary health care services. And these charges will be similar to the current fee level of the WHCs under the Department of Health. We will adopt the affordable users pay principle. We will assess the service efficiency of the WWS operator and monitor service utilization to ensure efficiency and quality. For the underprivileged, including CSSA recipients as well as those who benefit from the fee waiver scheme, they will be directed to the GOPCs under the HA to receive the relevant services. They will receive those services free of charge. At the end of this March, the HA rolled out this service. It is expected that every year 6,500 eligible women will benefit from the scheme. It is expected that the scheme will be extended to GOPCs in all 18 districts by the end of this year. We will, based on our experience, improve the other types of services, including elderly care services. We will integrate these services into our primary health care framework so that we can achieve the goals set out under the primary health care blueprint. We want to offer more human-centric services for those in need. We welcome any views from members. Thank you. Thank you, Undersecretary. Ms. Rebecca Chen and Ms. Jovi Chen have asked to speak 4 minutes for each member, questions and answers inclusive. Ms. Rebecca Chen, please. Ms. Jovi Chen. There are 3 items today, so, it is mentioned in the paper that it is expected that the WWS will benefit some 4,000 eligible individuals. However, the GOPCs under the HA as well as the district health centers have already served over 110,000 people. The WWS in Kowloon and the new territories will commence operation in September. However, will they be able to serve all the people in need? Now, the first phase of breast cancer screening will be offered by the Primary Healthcare Commission, but the second phase will be offered by non-government organizations. Will WWS learn from the service model in the first phase to continue to offer breast cancer screenings for those in need? For example, will they be referred to receive ultrasound scanning services? Also, in the second phase, what will be the division of work look like to benefit more women in need? While there is still time left, I will ask one more question. To benefit more women from the grassroots, including women of ethnic minority, will the district health centers as well as the women wellness satellites make educational services part of their regular services? I know that a lot of places in Southeast Asia, they make breast cancer screening a screening for all their people. So will there be more services relating to breast cancer screening offered by the WWS in the future? Well, I'm happy to be here to answer members' questions today. Now, concerning screening services, under the Department of Health, there is a scientific committee comprising of experts that look at the clinical data to see what kind of screening services we should provide, and we adopt a risk-based approach as we rolled out screening services. So we'll only work towards the direction agreed by the experts in the committee as well as the government. We have all along been adopting a risk-based approach, and so the Primary Healthcare Commission adopts the same principle as it rolls out the screening services. I'll ask Dr. Pang to see if we have enough capacity under the WWS and how we will offer more breast cancer screening services in future.
Thank you. There are 2 parts to our service of women's health. We offer counseling and education services. The district health service offer group classes and also individual services. Women may also suffer from hepatitis B and 3 highs. They can receive relevant education in the district health centers. People have to go through a risk assessment to see if they're suffering from breast cancer. We have to educate the people in this area. And we offer this service at the nurse clinics. This service offered by the nurse clinics is the same as that of the WWS. So people will go through the X-ray scanning and the cervical cancer screening at the WWS. So we promote the women's health on a holistic manner. Thank you, Ms. Chen Hao-Yan. We are concerned about women's health. We want to achieve early detection and early treatment to lower our health expenditure. We're going to set up 3 WWS. The Department of Health will be funding the WWS. According to your information, the DH procure for the 3 WWS together, the cost is as high as $530 million altogether. So I wonder how much of the $177 million per year is spent on the WWS, how much is spent on the district health center. The operating cost of each DHC on average is $60 to $70 million per year. Take the Central and Western DHC as an example. I assume that it spends some $70 million a year. In other words, the operating cost of the 3 WWS is $100 million per year. So what is the operating cost of the Women's Health Cancer Center of the DH? It's about $20 to $30 million. It never exceeded $40 million per year. Now, as we engage contractors to operate, the operating cost is now some $100 million. So are the WWS offering more service than before? It seems not. But the cost is 20 to 30% higher, or 2 to 3 times higher than before. Now we are having a fiscal deficit. We have to be prudent when we spend our money. You didn't talk about the costs of operating WWS in your paper. Second, on menstrual irregularities and different type of testing, as they involve maybe some kind of disease, will you ask doctors to station at the WWS so that patients don't have to go for follow-up consultations at the public hospitals? You should be able to offer one-stop service as the WWS. Lastly, you're going to adopt the same operation model at the elderly healthcare centers. So I'd like to know more about how you spent the money. Undersecretary, I will take the question first, and then Dr. Pan will elaborate. On healthcare expenditure, as we engage the PHC in offering or operating the WWS and the elderly healthcare centers, the cost incurred is the same. We ask the Primary Healthcare Commission to offer more service at the same level of cost. I will ask Dr. Pan to elaborate later on. As to whether we will ask doctors to be stationed at the WWS, as WWS is part of the primary healthcare system, some of the diseases may be identified outside of the WWS. Some of them need to be treated by gynecologists, for example. We will put in place a bi-directional referral mechanism. I will ask Dr. Pan to address your other questions. Some of the funding is for initial setup of the WWS. They may have to procure infrastructures or a service from laboratories. Because when the women's health centers was operated by the DH, the relevant laboratory work is done by the department itself. Now the operator have to engage a service provider. Also, WWS operating hours is different from the WHCs. And they also have to perhaps upgrade and establish their own computer system. So the cost will also cover the system upgrade of all 18 DHCs. As we procure the service from the Strategic Procurement Office, the DHC will be able to share the service. So from liaison to DHC, the establishment of the system, to the service procurement for, say, mammography of breast cancer and laboratory testing, as well as value-added service to be provided by the WWS. The cost incurred in operating it will be higher. We will continue to review the cost effectiveness of the service. The Undersecretary said that no additional resources will be allocated to WWS. But just now, Dr. Pan said that they need to establish infrastructures and computer systems at the WWS. So will the contractor be responsible for shouldering the cost? Well, what I meant was that the government has not allocated additional resources when we have the PHC instead of DH to offer women's health services. We did not ask the contractors to pay the cost out of their pocket, but in the fees that we offer to the contractors, we already cover the cost on computer system and other infrastructure. Mr. Chamberlain, Deputy Chairman. Thank you. According to the paper, is service points and service hours for service volume and scope of the WWS is wider than the WHC. It is said that during the transitional period of service integration, the 3 WHCs and 4 MCHCs under the DHFCs accepting new appointments starting from 24th of January 2025, So why don't we have the WHCs and WWS operate in parallel? We have WWS and we also have the elderly health centers. As a Father's Day is coming up, why don't men have a dedicated health centers? Because men have their own problems, so will you consider it? I will ask Dr. Lam to talk about the service hours. We're looking into offering service for men in particular. Dr. Lam, please. Thank you. The WHC under DH have women registered for the service. So why don't we offer service to those registered under the WHC at the WWS? Members who are registered with the WHC would already have paid a service fees, and the fee will allow them to receive service for a year. They may want to continue to receive service offered by the Department of Health as they already paid the annual fee. But if they want to enjoy service offered by the WWS, we welcome them to register or make the relevant registration at the DHC. Now it's my turn. In the future, in the WWS, you're going to offer different kind of service. Will you procure a service from the community laboratories? Will you engage family doctors or gynecologists at the WWS? If they're family doctors, will their service duplicate with that offered by the family doctor clinics? Thank you. I will ask Dr. Lam to address the question. We'd like to adopt the model of the CCEDC pilot scheme, but during the transition period, we're going to put in place special arrangement. Dr. Lam. Thank you. Regarding the service arrangement, if a certain person has special needs for assessment or cancer screening, at the DHC in the 18 districts, we do offer such service, and the relevant person may be referred to the WWS. We have specialist family doctors stationed at the WWS offering services to the people. In the future, we're going to offer value-added service starting from September this year. Thank you. People usually stick to the doctor that they go to. Some people may be used to going to the GOPC. That's why they may be reluctant to go to WWS. Dr. Pan will elaborate. Thank you. WWS only offer screening service and service of limited scope. Before our people go to the WWS, we're going to match them with a family doctor. If their own family doctor are not listed under the WWS, we will try to invite them to participate. As we are still purchasing relevant service, we will talk to the family doctors when we have more detail. Thank you. Thank you. Item 6, any other business? There being no other business, meeting adjourned. Thank you.